Good afternoon, everyone. It's lovely to see so many of you from all over Europe come in to this session this afternoon. I've been asked to talk about randomised controlled trials, and we've heard from Jonathan that it is an area of research that is considered to be at the sort of top end of the pyramid, although he obviously views that the pyramid could be jumbled up a little bit. But some of you will be familiar with this. This was Richard Horton's contribution in a commentary from 1996. And just to explain, he was an editor of The Lancet. And in this commentary, he was more than scathing, I would say, about the quality of surgical research at that time point. If you read the article, he commented that most of surgical research revolved around case reports and case series. He'd done a straw poll of journals that had been published at the start of that year and found that only 7% of papers in the sort of top level surgical journals at that point were actually randomised trials. Obviously, we've moved on since then, and I think in terms of surgical evolution of when you're looking at techniques, I think the ideal framework really has taken the arguments that were pitched against the surgical community in 1996 forward, and some of you will be familiar with this, but for those who aren't, well, the ideal framework describes how a new surgical technique or technology should be brought to routine clinical practice. So stage one is that first report, it's one surgeon doing it on one patient. And if that's successful, you then move into stage two, where it's done perhaps by a couple of surgeons on a few patients. And then that moves through to stage 2B, which is the exploration, where it's done by a few more surgeons on a few more patients, and you ensure that this is a safe and practical thing to be doing. And then this is where we get to the sort of crux of what I've been asked to talk about today, that should then be evaluated in a multi-centre randomised trial to work out whether it is what we should be doing in our practice. If we look at what the surgical publications have got today, I did a similar straw poll and chose just to do the top 2 impact factor journals in 2024 when I was putting these slides together. And actually, I was reasonably pleasantly surprised to see that 24% of the papers in those journals were actually randomised trials. I inherently felt it would be less than that. Certainly as a journal editor, you perceive that you want more trials. I know in BJS, typically on an annual basis, less than 10% of our submissions are still randomised controlled trials, and we would dearly love to see more. Why don't we see more? Well, it's difficult. Jonathan sort of touched on this a little bit, but doing randomised trials in surgery, I would argue as a surgeon, is more difficult than comparing a drug A versus drug B in a rheumatology clinic. There's the sort of nature of surgery. We sort of evolve through developing surgical techniques. I think the nature of many surgical diseases make it more difficult than that rheumatology clinic. A lot of surgical pathology presents as an emergency, and it's not impossible to do a trial in emergency surgery, but it is more difficult. It's more difficult when patients are presenting out of hours and you don't have the research team there to do it. I think there's also a pace of change in surgery. It was mentioned earlier about robotic surgery, and 10 years ago, robotic surgery for colorectal surgery, which is my area, was in its infancy. And rightly, people said, well, we need to evaluate this with trials, and trials were designed, and those trials took a little while to design, and then they took a while to recruit, and they've reported in the last couple of years, and yet the world has continued to move on. And now if you speak to surgeons who do robotic surgery, most of them would say they wouldn't go back for rectal cancer surgery, and yet the evidence base doesn't exist for that. And that is another challenge with surgical trial design. In my eyes, perhaps the biggest difficulty is equipoise. Surgeons, it's difficult to find true equipoise in a surgeon. You always feel that there's one way that's better or another. And if you've got that inherent gut feeling that there's a difference between techniques, to then try and articulate that to a patient who you might be hoping to recruit to a trial, I think is difficult. And certainly from the patient's perspective, if you say to a patient, well, you've got rheumatoid arthritis and tablet A is what we'd normally do, but we think tablet B may or may not be better and we'd like to try it, they can kind of accept that. If you say to a patient, well, you've got such and such condition and I can offer you an operation where I do a big cut on your tummy, or I do it with minimally invasive surgery, most of them will perceive that minimally invasive techniques will be better. I think it's also difficult to standardise surgical trials, and this is, to give you an example, if you ask 10 of us who are trained surgeons to do a laparoscopic appendectomy, I'm fairly sure all 10 of us would do it safely, But all 10 of us would probably do it with a slightly different technique if you looked at it. If you looked at what ports we used, if we looked at what access we had, if we looked at whether we used ender loops or a stapler, or all these things are very difficult to standardize. And also when you have a new technique that comes to the fore, there's a learning curve associated with it. You know, my particular unit has only just got a robot. So if I was going to take part in a trial of robotic surgery, well, I'd be very much on the beginning of my learning curve about how to do robotic surgery. So if I was recruiting patients for either laparoscopic or robotic, it could be argued that I can do it better laparoscopically than robotically. And a surgical patient's journey is a fairly long one. You know, it's not just about the 2 or 3 hours that they're in the operating theatre. There's the pre-assessment, there's what anaesthetic is given to them, there's what happens to them on the ward afterwards. All of these things will influence the outcomes of a trial that you might want to do. If you look at what has gone on historically with trials, I have to say the results of this paper that was published a couple of years ago don't inherently surprise me, but they do disappoint me. This group looked at the clinical trials registration website for trials that had a surgical component to them registered between 2010 and 2014. You can see a large number of trials. Only 1 in 6 were actually completed on time with full enrolment into the trial. Less than 50% of them met their enrolment target, and 1 in 5 of them were actually discontinued. And to run a trial takes a huge amount of effort from the researchers, financial commitment, and the fact that 1 in 5 of them were actually discontinued, I have to say, is a concern of somebody who's involved in surgical research. What do the people who are involved in surgical research think of the challenges? Well, this was another interesting paper that I came across from BJS Open from the last couple of years. So this was a survey type paper looking at data from people involved in surgical research in the UK, and one of the questions that was asked was, what are the main barriers to recruitment? Well, equipoise clearly comes through as two of the top 3, both in terms of patient and clinician opinion, but also clinician time constraints, and I have to say this is something that I very much feel, you know, as a clinician working in the surgical world, time to recruit patients and things like this is a challenge. I think it is an area where, as a community, there's an opportunity for us to improve that. You know, if you give surgical clinicians time to be involved with research, you would hope that statistic would improve. So if these are the challenges, how do we do better? Well, I think we can do better. That's the first thing to say. I think I'm going to share with you some of my thoughts about how we do that. And the first step in the journey of doing a trial is, well, what is the research question? And I think we should only really be doing trials in questions that are relevant. We've seen in recent times increased involvement of stakeholders or patients in designing research questions. And I have to say, I think that's personally to be applauded. You know, I think the surgeons, in terms of our research, we've historically been relatively paternalistic in that we thought we knew what our patients wanted. And I think involvement in patients more has taught us that perhaps we don't. So I think that's where you start with this. Having come up with the research question, I think it's really important to work out whether the answer to the question that you've come up with is actually known. So a well-done systematic review of the knowns, if you like, is the next important step. And having got the information about whether a trial is needed in this area or not, we actually need to determine early on what is going to be the research question. And I think the PICO framework, in my eyes, is a very useful way of doing this. So first part of that is obviously the population, and experimental versus pragmatic. What do I mean by that? Well, to give you an example, when I started in Swansea, we set up a randomised trial looking at surgery alone versus radiotherapy for lower third rectal tumours. And I appreciate not all of you are colorectal trainees. So at that stage, pretty much it was recommended that anybody with a lower third rectal cancer of any pathological stage had radiotherapy as part of that treatment. And as a group of clinicians, we felt that probably wasn't appropriate with some patients with earlier stage disease. So we set about setting up a trial to compare that, and went through all the hoops, and we set the trial up and ultimately failed to recruit because there were not that many early stage rectal cancers that were able to be entered into that trial. Now, That, I think, from a trial perspective, was a very pure research question. It was early stage disease, but from a pragmatic perspective, it failed because there weren't enough patients for us to be able to recruit and complete the trial. If you compare that with a more pragmatic approach where you have a sort of wider inclusion base, that would hopefully get more numbers through, but you also need more numbers to show true significance in the trial. We then need to decide on what the intervention is, and in most surgical trials that's probably going to be a new technique or a new operation, and decide what you're going to control against that, and usually that will be what is already established as the best practice in this area. And decided on that, you then move on to what your outcomes are going to be, and I think this is really important, that if you don't get the correct outcomes at the start, you're probably going to fail when you come to analyse your trial. And again, I think we've moved on with this, that we're more and more seeing core outcome sets in certain disease types in general surgery. And I think that's important and to be applauded, and that will make designing trials perhaps easier, but also when you come to do meta-analysis, etc., of the trials that are available, having core data sets will improve that. Having got your research question, I think if we'd gone back to that rectal cancer trial where we failed to recruit, if we'd done a feasibility study rather than just launching the trial, I think we would have probably worked out that we shouldn't have done this. And I therefore think for most trials that you may embark on with a surgical slant, a feasibility study is a very good idea. That will work out whether you will recruit or not. Your unit may think it's a really important question, but will other units have a similar view? And that will establish that. It will also inform your sample size. And I can't overemphasize the importance of somebody like Jonathan at this stage of sort of trial design. Really get your statistical input as early as possible. And please don't forget to register your trial. I have to say, not infrequently we get trials into BJS where the trial has not been registered a priori, and that really from the BJS's perspective is going to be it's not going to be published with us. So that's really important and occasionally overlooked. So what as an editor do we look for? Well, in terms of randomized trials, I have to say they're sought after, and we get a weekly influx of emails with, if you like, editors post back. And if there's a randomized trial in it, I have to say personally, I'm reasonably excited about that. And from a start, as an editor, you've got a sympathetic eye to that paper. You're more inclined to want to accept that. You're looking for its strengths rather than its weaknesses, I suppose. It stands to reason that we're going to be interested in topical, novel and relevant stuff. But I also think it's important to state, certainly from the BJS's perspective, that really the trial design is the most important. The hypothesis and the trial design, even if the study is a negative one, we'd still look to publish that. Unfortunately, the medical literature, it has this bias towards positive results, but in terms of trial reporting, we very much would look to publish an in inverted commas negative trial. What's going to turn us off this paper that's come in? Well, there are some fatal flaws. As I've said, not registered a priori is one of them. If you haven't got ethical approval for a trial, you're not going to get that published in most recognised journals. Lack of a power calculation at the start. And then you're looking for the sort of biases, and I think the sort of RAMBO acronym is useful when you're looking at a randomised trial to work out where biases may exist. So, in the modern era, I don't think there's any need for randomisation techniques like date of birth or postcode or things that could introduce bias. Should be relatively simple to do effective randomisation. Jonathan mentioned on this, but attrition, what you're looking for is, did the number of patients who start the trial finish or have data for at the end of the trial? You're looking at what was measured. Is it relevant to the research question? Whether the study has actually been blinded or not, and then how those measurements that they were looking at, how have they actually been measured? Have they been done objectively? Have they been done by blinded individuals? Has it been the researchers themselves doing them? When it comes to writing up your research, I have to say, I think the hard work for people writing up randomised controlled trials has been done by the consort checklist, really. I think this is your starting point when you write it up. There's the original version, but there are extensions out there for most sorts of trials now. It was interesting when I was putting this together that I wasn't aware of this, if I'm honest, that Spirit and Consort have got together and they're going to give us an updated checklist at some point this year. So in conclusion, I think we have seen an evolutionary improvement in trials in surgery. Certainly from an editor's perspective, there's an appetite, a need for more. Really, the sort of planning of your trial is the critical stage. And when it comes to write-up, I would say checklists, and more checklists. Make sure you use them. They're out there. They're there for a reason. They will make your research easier for somebody else to read, which is the point of your write-up. So in my eyes, I don't think we are a comic opera anymore. Thank you.
So thank you, Martyn. Any questions from anyone around the table? Martyn, why don't I start things off by asking you about per protocol versus intention to treat, and where that sits with us in terms of actually getting a result from the trial that we think's relevant to our personal practice. Because I'm always a bit confused about, I appreciate what statistically should be used, but my patient, because if I've randomized my patient to a laparoscopic operation, but they've had an open operation, then that's what's actually relevant to them. Are you able to disentangle those in terms of statistical benefits versus what it means in the real world?
I agree with you, Peter. I think it's difficult, and in a minute I'll look to bring Jonathan in for his comment with his statistical head on. I mean, I think from the purist perspective, the intention to treat is where you need to start that question. At a pragmatic level, you're right that you actually want to know the results of what was done rather than what was intended to be done. And particularly, in the setting that you've described with minimally invasive, for sake of argument, versus open, do the patients who then crossed over actually end up doing worse as a consequence of having been in both sides is one of the critical questions. From a statistical point of view, Jonathan?
I can speak for just the Mike. So from a sort of principled a priori, I thought the as randomized group is the one that you've generated. You expect to have fair comparison if you compare them. So in principle, you'd want to compare them. However, it does matter who got into the RCT, what happened to them, and what data you've got on them. And I think what I always try and do is try and separate out the reasons why it didn't go as sort of planned, so to speak, as on the initial intent. And some of those are different. If you were going to do robotic surgery but the robot didn't work, then that's quite different from trying robotic surgery, not being able to complete one of the steps of the surgery and therefore having to move to a laparoscopic procedure. Those are quite different, and you could argue that conversion is part of what at the moment robotics might lead to, because it's not nimble enough, it's not able to be used to do a certain step for a more difficult patient. Or is it that you've opened someone up and you realise that actually they're a bit different from what I thought and I'm going to do something different? Then the intent is not really just the specific procedure. The intent is I'm going to plan to do that one, but I'm also going to deviate if I know that that's not going to be good for the patient because it's going to be impossible, or I guess it's less common with scanning technology, but I thought they had this problem, I've opened them up and they don't. You can't go through with the operation to fix the thing that doesn't exist. So clearly that's natural to and what you're evaluating is the wider approach, which is conditional on all these things about who kind of gets operated on, how did they get in the study and what not. But I think for an RCT in general, I'd still expect an as randomized or intention to treat analysis to be there, and most likely it would be what I would think is the first analysis. But then you do have to explain patients and consider the complexity. There are approaches to try and look at taking into account what actually happened to them, and there's some more sophisticated approaches than just analyze them as they received, because that can bring a lot of biases. Those who switch over tend to be the difficult cases, and therefore you might be unfair to the other group. There's kind of more interesting approaches, but they tend to need large sample sizes and richer data to be able to implement.
You're right, when you're reading the paper, that switchover group are the ones that you want as much information about as possible as a reader or somebody reading the paper for a scientific interest. So.
Yeah.
Funding. So RCTs, you probably don't see so many in your inbox because they're so expensive and it takes so long to run and all that stuff. So yeah, in your how to do RCTs better, is there an effort to help with funding and getting, keen budding academics into good funding streams? I know NHR is represented here somewhere and MRC and whatnot, but
I certainly think you've hit the nail on the head in the UK practice, and I appreciate not everybody is a UK audience, but if you look at what's happened in the UK since I started my training, did my research, and then became a consultant, the NIHR really are looking to fund more surgical trials. It wasn't on the agenda at all a decade or so ago, and one of Dimitri's sort of colleagues, Dion Morton, amongst others, has really championed that along with the Royal College of Surgeons to improve that. I think globally there is a recognition that surgery needs to do more trials, and I think there is more funding now than there was historically. The reality of any funding type debate is there's never enough funding to do everything you want to do. That's healthcare. That's whether you talk about funding healthcare and treatment, whether you talk about research. It's always that way. So I think things are improving. With your surgeon's hat on, I'm sure there's not enough funding, but I think the wheels have changed in my eyes significantly in my time involved in it.
Thanks very much. One last question for me. So the robot's been rolled into Swansea, and you're an excellent laparoscopic rectal cancer surgeon, Martyn. I'm not an excellent laparoscopic rectal cancer surgeon. I think I'm an okay robotic rectal cancer surgeon. When does it get to the point where it's too late to do an RCT for robotic rectal cancer surgery? Have we reached that point? How? Because an oncologist is almost never going to give a drug that hasn't been through an RCT. So I presume surgeons must be very different in their ability to go and sort of wield the knife without randomized evidence. How do we satisfy that when we're talking to our patients saying we're going to do this with the robot?
I think it's really difficult because, as you know, and some in the room might not, there's no really high quality evidence for robotic surgery. Yet you, as somebody who's been trained on the robot, will say it's easier to do it robotically than laparoscopically. And I think if you can wake up and look in the mirror and say, I'm going to do this the best way for my patient today, that's probably the answer. You're not going to push yourself to do it laparoscopically to be part of a trial lap versus robot because you inherently feel that you'll do it better with a robot. But it is difficult, that is why surgical research is different, I would argue, from medical research or oncological research, because these things do evolve. When will I do robotic surgery? I'll be mentored and I'll make a decision based on that. I think whatever you do, it's important that it's done safely, and that's about the ideal framework. That's about when you have a new technology, it's not necessarily a statistical thing, but you have a new technology like robotics in your unit, you don't just go gung-ho and say, I'm going to use it for everything. You have somebody there who knows how to do it and shows you how to do it rather than just taking it forward on your own. Will there be a trial that shows it? Probably not, I suspect now. I think the world has moved on in the robotic debate, certainly in rectal cancer surgery.
Thank you. So Jonathan's now going to come and give us some statistical pearls in relation to randomised controlled trials. Thanks, Jonathan.
Okay, so I'm going to just give a very brief sort of statistical consultant's view on papers that I receive, focusing on the different study types, and first of all on RCTs at this point. So what I would emphasise is RCTs are comparative studies. Thankfully, it's not that common on the papers I see at BJS, but you do see people have done an RCT. The whole point of them is you randomise, you create these groups so that you can compare them fairly, and then the paper somehow gets sidetracked and it's doing these analyses that are really make the whole process of randomisation irrelevant. And that's not the way that we should analyse them and the way we should deal them. Another thing to bear in mind is that the data that's produced by an RCT can be used to look at different types of questions, and quite rightly that's good to do. They're expensive. If we've got data, let's do that. But it is a different study. It's not something to just stuff in a little paragraph, a whole different type of research study where you're not going to explain the methods very clearly. but then you want to jump to some big conclusion. We can confidently predict this complication based on X, Y, and Z. So do bear in mind that that is a different research study if you're doing that, looking at risk factors or prognostic modelling or something similar. I've already emphasised it, but account for everyone randomised. Whatever happened to them, what happened to them in terms of the interventions, it's really important. The more information you get for those that didn't go as planned, the better for other people to understand. And be honest about your missing data. I have missing data in my studies. You'll have missing data in your studies. I don't believe you if you say you've collected hundreds of outcomes on hundreds of people and yet somehow you present these tables as if it's perfect and no data is missing. That just doesn't happen in clinical practice when you're working across multiple institutions, multiple surgeons, multiple areas, multiple types of outcomes that aren't automatically collected. And then lastly, Consort has been mentioned. It's excellent. It helps you report your studies. It doesn't tell you what to do. Sometimes I see that written in papers. Consort, we followed Consort in the conduct and reporting of our study. No, you didn't, because Consort is not a conduct standard, it's a reporting standard. However, it does sort of imply certain things. So you can get nuggets about conducting RCTs because it tells you what you should know about, because it tells you need to be able to report it at the end, but it doesn't tell you what to do. And then in my particular area that I was focused on, the method section, do report all the statistical methods you've used. Don't just sneak one in that I find in the supplementary data or some little bit in the results. That happens quite commonly. And also be clear about what you analysed, which outcomes and how you analysed them. It's not okay to have a general statement that says, I used a t-test or I used this, depending on the outcome. That's not good enough for me. I wouldn't expect you to describe your operation as, oh, I used a robot or I didn't use a robot, I might have used a laparoscope and I might have had some ports and I did some things, maybe or maybe not, depending on the patient. That's not a good way to describe an operation, and it's not a good way to describe statistics.
Do you mind if I ask you a question,
Sure.
Jonathan? So most randomised trials have what I call table 1 as an editor. That is the table that compares the two groups. Should they be compared statistically or not? And I have to say, I've seen this written both sides many times over the years.
If you send that in and I review it, I will say take out any p-values. Crudely put, I'll say take out any p-values associated. There's a few reasons why that's not a good thing. If you have randomised, then and you do a test and you use a 5% level, that's saying that there's a 5% chance that you'll get a p-value less than 0.05, even though the groups are in essence identical. So 5% of the time you'll get the false result, and you know that. And then if you do that for like 20 different outcomes, very likely one of them is going to come up significant if you've got a sample size of a reasonable size. So it's not really very useful practically. It's not a very good also way to tell whether it really matters. If you have a very large study, you test age, you might find there's a significant result which equates to a 1 year average mean difference in people. Does that really matter for most operations? I doubt it does. Maybe for pediatrics, but not for, I don't know, operating on men in their mid-50s. Does it matter if they're 55 or 56? I presume it doesn't make much of a difference.
One more question then about missing data, if that's one of your bugbears. How do we deal with missing data? Do you support imputation? Do you support a analysis method that would actually just drop that patient, or is it case specific?
Yeah, that's a good question. So what I'm arguing for is to be honest about the level of missing data for all of the bits of information, the key bits of information you're reporting. And I say I have seen papers that give the impression there was no missing data for anything at all. I don't believe it, so I always have a query about that. I then also want to know if you have missing data, which I expect you will have, because even the best studies have some, to say what you've done with it. And I do still think in most situations, the default safest thing is just to analyse with the available data. And if you've been honest about the amount of missing data, other people can make a judgment about whether they think that's problematic. And in an RCT, to a large extent, not exclusively, it's a proportion between the groups. If they're similar, that's generally quite a reassuring sign. If someone's done an RCT and used reasonable approaches that are consistent across groups, that's very reassuring. There are methods to try and do better. Some, like the imputation methods, try and say, well, what would be the result? Those are, if you think it through, necessarily a little bit unsatisfying, because if you knew the answer, you wouldn't be doing multiple imputations. So you're trying to guess an answer based on the data you have. So there's only so far you can go with that. And it's only really rewarding if you have other information that really explains why someone was missing, i.e. this patient didn't come to OR because they had a serious complication with the first stage of the operation. That's useful information. If they just don't turn up and you don't know why, in terms of what you see as data, then you don't know what to do with that. And if you've just got the same data that you were analysing with anyway, their age and their stage of disease, then you've not really changed anything in terms of imputation model. I think the more interesting ones, although I don't think we've got it fully set in statistics, are methods that try and look at how robust are the results to missing data, as in, if you assume certain things about the missing data, would it shift the result or wouldn't it? Those, for me, I think they're the more satisfying kind of approaches that are used a little bit. I'd like to see them used a bit more.
So that implies there's some sort of systematic reason why there is missing data.
Well, I think the latter approach is, I think it's hard to know that for certain, and so the other way to approach is, well, how different would the missing data have to be to make it change the result? And often you find actually, although it's a sizable amount, if you expect the same amount in both groups, it won't change the result. Any sort of reasonable reference point.
Okay, thanks very much. Thank you.